The TCD Projects LLC presented video number 1 online training 2020, transcranial Doppler monitoring, anatomy, technique, TCD emboli monitoring. Anatomy. Number 1. Our first recommendation, locate the transtemporal window. Remember, hypostosis of the skull has been recognized by workers in the field of transcranial Doppler ultrasonography as a major obstacle for transtemporal isolation of the basal cerebral arteries, particularly in elderly women. Certain population is more significant: Asian, Afro-Americans, Hispanic. 3. Position of temporal window vary according to head circumference. Anatomy of the circle of Willis. The majority of the TC monitoring are focused in the MCAs, but we can isolate a different vessel according to the physician request. The MCA passes laterally just underneath the frontal lobe, has the large diameter and supplies 70% of the blood in the brain. TCD depth: 50 mm depth for MCA M1 segment, 40 mm depth for MCA M2 segment. We isolated parallel focusing slightly medially. Assuming the angle is 0 degrees, we move the transducer slight up and medially. Technique: our recommendation for TCD monitoring is first performed a routine TCD in order to locate transtemporal windows. If you are a newbie or beginner TCD technologist, here our recommendation. Once you find all your vessels in the right anterior circulation, mark the spot using a skin medical marker, then proceed to do the same in the left side. Patient position always supine, face up, lying down in the examination table. Once you finish the routine, scan, prepare, and set up your equipment and supplies for monitoring. Marking the transtemporal window after routine TCD. Technique: adjust the head holder according to the head circumference. Set up the head holder, push down the posterior part, and try to reach the occipital bone. The anterior part should reach the eyebrows. Adjust gently to make sure the holder is stable and avoid any unstable movement of the head holder. Make sure of that when the eyebrows move up and down. Equipment and software should be open and ready. Make sure both transducers are plugged in the correct connector. Ultrasound signal is working and right and left windows are labeled. If you use the skin marker, just follow the marks and place the transducer in place. Find UMCA starting by the right side. Then proceed to lock the screws in the transducer holder. Make sure the waveform signal is ready and make sure that it's tight enough. Start monitoring, pressing U Start Record button. Technique: adjusting head holder. Push down reaching occipital bone. Adjusting head holder forehead/eyebrow. Placing transducer mark after temporal acoustic window. TCD equipment ready for emboli monitoring. TCD emboli monitoring. Types of embolism. This is when part of a blood clot thrombus blocks blood flow to a major organ such as the heart or lungs. Is the most common type of embolism. Arterial embolism. This is when one or more blockages form in major arteries, often as a complication of heart disease or arterial fibrillation, a heart rhythm disorder. Venous embolism. This type of blockage is caused by a particle of fat or piece of bone marrow, which is sometimes released from a fractured bone. It is much less common than an arterial embolism. Cerebral embolism. This is when an embolism, usually a blood clot, gets trapped in the artery in the brain. It's one of the most common cause of a stroke. Cholesterol embolism. This type of embolism can form by itself or following treatment to widen arteries if they become blocked up with fatty deposits, plaques. Tiny crystals of cholesterol sometimes released from fatty deposits and can cause blockages in small arteries. Brain emboli, consisting in white cells and platelet aggregates, fat or air, may be implicated in large focal neurological deficits such as stroke. Macroemboli, less than 200 μ in diameter, or in more subtle diffuse cerebral dysfunction such as neurophysiological disorders. Microemboli, less than 40 μ. TCD emboli clinical application in different potential diagnostics. Asymptomatic symptomatic carotid stenosis. Intracranial arterial stenosis. SAH, subarachnoid hemorrhage. Aortic arch atheroma. PFO, right to left shunt. Artificial heart valves. Acute stroke, TIA. Hyperbaric decompression with and without symptoms. Angioplastic stenting. Dissection. CEA, cardioid endarterectomy. Orthopedic surgery. DVT. CABG, coronary artery bypass. Invasive procedures, stenting, cerebral, coronary angiography, hemodialysis. Emboli characteristics. A Doppler microembolic signal is transient, usually lasting less than 30 milliseconds. High-intensity signal visible in Doppler spectrum, occurring randomly. Characteristic chirping or clicking sound. Embolus size, proportional signal. Blood volume and sample gate, weaker in large sample volume. Ultrasound carrier frequency. Ebolus display dependent on ultrasonic frequency. TCD emboli detected, 2 names below. Microembolic signals, MES. High-intensity transient signals, HITS. PFO TCD bubble study. In 1877, Dr. Julius Conheim initially described the term paradoxal embolism, PDE, and the association of PFO with stroke in a young woman with cerebral arterial embolism. However, it has been difficult to diagnose PFO in vitro until the development of echocardiography and its ability to image the internal shunting with the injection of saline contrast. With the use of contrast echocardiography, a strong association of cryptogenic stroke with PFO has become evident in patients less than 55 years of age. A paradoxical embolism refers to an embolus which is carried from the venous side of the circulation to the arterial side or vice versa. What is known about PFO and stroke? PFO occurs in up to 26% of all adults. PFO is diagnosed in 50 to 70% of patients with stroke of unknown cause. After a first stroke due to PFO, one half of patients still have moderate to severe disability after 1 year. After a first stroke due to PFO, second strokes occur at a rate of 2 to 9% each year depending on risk. After several strokes from PFO, repeat strokes occur at a rate of 6 to 20% each year. The risk of repeat stroke due to PFO is increased in patients with leg clots, migraine headache, atrial septal aneurysm seen by an echo, and a large PFO shunting seen by TCD. PFO has been associated with numerous conditions such as decompression illness in divers, migraine, high-altitude pulmonary edema, cerebrovascular and coronary ischemia, and obstructive sleep apnea syndrome. Identification of patient with foramen ovale in patients with cryptogenic stroke or TIAs. Cardiogenic brain embolism is one of the major causes of focal brain ischemia. Potential cardiac sources of embolism can be identified in about 50% of consecutive TIA or stroke patients in TEE. Albers et al. 1994. After birth, right to left blood flow is no longer needed. Two dividers in the right and left atria fuse to form a solid wall, septum. The septum is fused in 90% of people by 18 months of age. However, the dividers which form the septum do not fuse in 10 to 30% of people, leaving a flap or tunnel which may open and close as right heart pressure changes. This opening, flap or tunnel, is the patent foramen ovale. Closure of PFO. Tiny PFO communications are low risk for stroke and do not need treatment. Large PFO are much more likely to result in stroke, migraine, decompression illness in divers, and low oxygen levels in the blood. Mistakenly thinking that all PFO are the same is one of the reasons doctors may disagree in PFO treatment. Size of PFO, large versus small, PFO showed no difference in recurrent stroke rates in both the RESPECT and REDUCE trials. So far, the results of clinical trials do not support routine PFO closure for migraine alone. However, observational data is still highly suggestive of a link, and in selected cases, it is justified. PFO and migraine. 50% of migraine patients have a PFO, and most of these have large shunts. The theory is that substances in the blood bypass the lungs and trigger migraine. Alternatively, small clots may pass through the PFO and trigger migraines without causing stroke. Scuba divers often have migraines after diving, and the chance is much higher in divers with large PFO performing deep dives where bubbles come out of the blood and travel into the brain through the PFO rather than stopping in the lungs. Our first understanding of migraine improvement with PFO closure came from divers with migraine and decompression illness. Classic migraine headache is a primary headache not due to stroke or tumor, which is usually one-sided throbbing. However, it may be difficult to distinguish migraine aura and stroke or TIA mini-strokes, which then cause secondary migraine headache. Famous cases of PFO. Ariel Sharon, 78 years old, Prime Minister of Israel. Patriots linebacker 33 years old Ted Bruschi, University of Arizona graduate, had an unprecedented comeback to professional football 8 months after suffering a stroke. Bubble injection. The TCD bubble test is a new, simple, accurate, reliable, cost-effective, and safe method for testing for right-to-left shunt PFO. Excellent non-invasive test, excellent sensitivity, especially with Valsalva. Excellent specificity, can be done in neurologist office. Supine position. Insert 18G, 22G needle into right cubital vein, isonate MCA. Syringe 1, 9 ml saline, syringe 2, 1 ml air. Connect both syringes with a 3-way stopcock connected with a short flexible line to an IV gauge with the patient. Exchange air saline mixture energetically at least 10 times. Inject immediately as bolus. Repeat examination with Valsalva. Valsalva should start on examiners. Injection of agitated saline mixture with air bubbles appeared to be well tolerated. No patients reported symptoms during or immediately after the TCD except 2 patients who reported hearing the passage of bubbles like sounds from a water stream. TCD bubble study syringe setup. Exchange air saline mixture energetically at least 10 times. Inject immediately as bolus. Repeat examination with Valsalva. Spencer scale to measure the size of PFO. O-grade RLS, a 6-level logarithmic scale, was used for both resting and Valsalva injections as follows. Grade 0 equals 0 ETs. Grade 1 equals 1 to 10 ETs. Grade 2 equals 11 to 30 ETs. Grade 3 equals 31 to 100 ETs. Grade 4 equals 101 to 300 ETs. Grade 5 greater than 300 ETs. HITS or MES. Microembolic signals, MES. High-intensity transient signals, HITS. Right MCA HITS plus left MCA HITS equals grades. Video TCD bubble study positive after pushing bubble result show or curtain. This video is endorsed by Dr. Alex Razumovsky, sponsored by CBD College and Compumedics DWL. Get in touch with us. Feel free to email or text and schedule a Class 101 or regular online session anytime. The TCD Project at gmail.com. Visit our website to stay updated. www.thetcdprojects.com. Book your appointment with us at 786-683-0083. 25101 The Old Road, Santa Clarita, California, 91381.